Good morning, good morning, good morning to everyone who is joining us. It is now 9:30 Central Time, 10:30 Eastern Time, and it's time for us to begin our training. We are very excited this morning to have our training focused on root cause analysis. I am Darlene Jenkins. I am Senior Director at the National Healthcare for the Homeless Council, and we have a special guest this morning who will introduce herself in a few moments. Just some housekeeping notes before we get started. This is a 90-minute training. So we will start just a few minutes and we should end around 11 Central Time, 12 Eastern Time. We would like for this to be as interactive as possible. So our chat box is open. If you have questions or any type of, wanting more explanation on something that our speaker is referring to or talking about, please do use the chat. We will stop in between the presentation to ask questions. I will be moderating and watching the chat box for her, and we will be ensuring that all questions will be answered as they are given, as well as time will be given at the end for any additional questions that you may have. So please use that chat box so that it can be interactive. Excuse me. Also, this is somewhat of a beginning of a series that the council is doing. This root cause analysis is kind of the launching pad. We will be offering 3 sessions after this, and I will put the dates in the chat if you would like to follow up with us to do more work on your root cause analysis. We will be offering 3 sessions, 1 in January and 2 in February, to just kind of help further the work on what you're learning today. So please look at the chat for that. And then finally, we will have an evaluation that will pop up at the end of the presentation. It will come through the Zoom. Please fill out the evaluation. This is the only way that we can really kind of tell if we're hitting the mark and if you need additional trainings. So please take the time to fill out the evaluations. It's very, very important to us. I think that is all at this time. So I'm going to turn it now over to our speaker, Kristen Bigelow-Talbert. Kristen?
Good morning. Thank you so much, Darlene. And good morning, everyone. Thank you for joining me this morning for the root cause analysis training. As Darlene mentioned, I am Kristen Bigelow-Talbert. I'm the Community Health Quality Manager at Bi-State Primary Care Association. At Bi-State, we have 22 federally qualified health centers and 1 lookalike FQHC across Vermont and New Hampshire. And I've been in the healthcare field for about 16 years now and been doing quality improvement work for much of that. I very much enjoy quality improvement, and I know that we have many folks in the audience today with a variety of expertise. For some of you, this might be old hat and review, and for others, you may just be dabbling in this. And so I want to make sure that no one is left in the dark. If you have any questions, if I'm going too fast, if there are any acronyms you're not familiar with, please, please, please put them in the chat. Darlene is going to be moderating that, as she mentioned, and she'll let me know if there are any questions as they come in. I really want to be able to answer your questions as they occur. Okay, so let's get started. We have 4 learning objectives today. Basically, my goal for you is that you will understand why we do root cause analysis in the first place, how to really develop a good, strong problem statement as your foundation, understanding the 2 most popular methods of doing root cause analysis, and then how to take the results from that and actually turn them into quality improvement projects that you can then act on. Okay, so why do this in the first place? I really think of quality improvement as something that, while it does take time, it will actually make your lives easier in the long run, because by not doing quality improvement, by not looking at our processes, you can actually make things more difficult for yourself without even realizing it. So in the long run, quality improvement can improve the quality of care for patients. It can make your lives easier, and it can actually improve things not only for your organization, but for the community too. Okay, so I get this a lot. Why bother doing root cause analysis? You already know what the problem is and you know what you want to do about it. So why spend the time to do this? Well, I like to think of root cause analysis and not doing that as almost like putting a Band-Aid on a problem that actually needs surgery. It won't fix the problem and the wound can fester. And I have a really good story to explain why root cause analysis can actually be really beneficial in the long run. Okay, so this is one of my favorite stories to tell because it's so, it really highlights how root cause analysis can save you money and resources in the long run. So this is about the Lincoln Memorial. The walls of the Lincoln Memorial were crumbling and they were really concerned about it because of course we don't want this to crumble and disintegrate. So they were looking at the problem and they said, well, it must be those airplanes that are flying overhead. All of those toxic fumes are coming down and it's deteriorating the rock. We need to reroute those airplanes, get them to go around so that this won't happen. So they were just in the process of starting to do that. And then someone from the National Park Service came in and said, well, wait a second, hold on. Let's do a root cause analysis first and make sure that's actually what's happening. So they decided to do that and they used the 5 whys approach. And they asked, okay, why is the Lincoln Memorial crumbling? And they got a team of folks together to explore this, which is important because then they were able to discover that harsh cleaning chemicals and a lot of water were used to clean it every day. And they asked, well, why are you doing that? And it turns out there were a lot of bird droppings all over the memorial that had to be cleaned off to keep it pristine and clean for the public. Okay, so then why were so many birds attracted to the memorial? Well, it turns out there were a lot of spiders living in the memorial, providing lots of food for all the starlings and sparrows, so it was like a feast for them. So then why were there so many spiders? You know, a question I would want to know myself, not being a huge fan of them. And then the reason actually was there were lots of these little tiny insects called midges, which would just swarm the memorial at dusk, which gave a lot of food to the spiders, which then fed the birds, which then resulted in the mess that had to be cleaned up every day. So then why were the midges swarming the memorial? Turns out they were attracted to the lights. So the lights that went on at dusk to highlight the memorial were actually attracting the bugs and resulting in this domino effect, which was resulting in the walls crumbling. So the solution was they just turned off the lights for the 1 hour time frame after sunset. After doing this for 6 weeks, they saw an 85% reduction in those little bugs, and it made a huge difference. So this is a great example of how doing a root cause analysis actually not only prevented them from spending millions of dollars, it actually saved them money, and it was a really simple solution. So it really highlights how this can really go a long way to save you time and money in the long run. I do want to note they're not doing this anymore, with the lights being off because of the public outcry. So if you go there at dusk now, you're likely still going to see the lights on. But this was happening for a while, and it did solve the problem at that time. Okay. So now how do you start a root cause analysis? Well, the first thing you actually want to start with is your problem statement. This problem statement will be your foundation, not only for your root cause analysis, but for your quality improvement work going forward for this project. You really need to do this before you start your root cause analysis. It's beneficial not only to have everything laid out crystal clear so you have your focus area, but also if you get your team together to talk about the problem statement, you may find that different team members have a different perspective on what the problem actually looks like. And it can allow you to come up with a comprehensive problem statement that really captures everything that folks are saying. While at the same time, and this is important, not being too broad. The reason why I say this is I've seen some really great problem statements that are really all-encompassing, which is great, but you kind of boil the ocean when you do that, because it takes such a long time to get through every little piece of a very broad problem statement when you're doing the root cause analysis, that it can take a very long time. So I encourage folks to really look at your problem statement and narrow it down. Look at the patient population. Make sure you're specific about who you're talking about. Make sure you're very precise in the problem that you're seeing and observing, so that you can really be focused in your root cause analysis. I also want to make sure to acknowledge that sometimes there's a problem because the data is showing there's something wonky going on. And other times it's anecdotal and you don't have data to necessarily support what you're seeing, or just that data isn't able to be collected on that problem. And both are perfectly valid starting points for a problem statement. While it's best to include data if you have it, it doesn't have to be included in your problem statement. That will come later. So when you get down to writing your problem statement, there's some things that you should include if you can, and things that you should not include at all. You want to make sure, if you can, to identify the gap in your problem statement. And what I mean by this is looking at your current state, where things are at right now as you see them, and where you want them to be. So what that gap is. If you are able to include a time frame or a trend that you're seeing, that's always helpful. If we're able to say, the no-show rate has increased the last 6 months, that gives you a time frame to look at, to focus on. That kind of thing can be really helpful when doing the root cause analysis, because it can focus your time frame to really kind of look at what's been happening during that time. Or a pattern. If you've seen a pattern, that can be really helpful as well. Including the impact here is helpful in the sense that it provides a sense of why you're looking at this in the first place, what the urgency is, what is so important about this that you need to be focusing on it. And this can be really helpful as we move into the quality improvement phase of things and you're trying to get buy-in from folks to move forward with any proposed changes. So having the impact in there can actually help you in the long run. If you have data, as I mentioned, include it, making sure it's relevant to the problem statement and not outside of the scope, making sure it's really kind of focused there. All right, so things to not include, and please, please, please don't include these. And it can be tricky too, as I'll talk about in a moment, but assumed causes of the problem. So if you think you know what's going on, even if you're pretty darn sure you know what's going on, don't put it in the problem statement. Only put in there what you see happening, the facts as you can see them, and do not put any assumptions or conjecture or opinions or belief in there. And this can actually be trickier than you might think, because sometimes some opinions or assumptions are so ingrained in your work culture or in the organization that you may see it as fact when in reality it's not. So really examine that as you're putting together your problem statement. At the same vein, you don't want to put in proposed solutions to your problem statement either, because then you're really steering the root cause if you're already saying, and we just need to do this to fix this problem. So do not put any proposed solutions in there. That will come later. It should not be a part of your problem statement. Make sure that it is, whatever you put in your problem statement is within the scope. You don't want anything external to that really fogging things up. And please, please, please do not include names of staff in this. We are looking at systems and processes and barriers. The actions of staff are the result of systems and processes and barriers, and therefore we need to focus on that and not staff. Okay, so I'm going to go through a few examples here of problem statements. So the first one states, 45% of our patients aren't coming to us for their flu shots because they prefer the timeliness of getting them at the pharmacy. Well, this part is you're assuming what's going on. You're assuming what the problem is. So we should need to take that out and instead examine the data, see what's really there. And it turns out they can revise it and say, we're actually missing information on whether or not 45% of our patients have had a flu shot this season. And if you notice, that actually turns things around completely. So not only are you no longer assuming the cause of the problem, you're also recognizing that you just don't have that data, which could be a completely different issue. All right, so next one. 30% of our patients with an A1C over 9 have not come in for their 3-month diabetic check. For patients with an out-of-control A1Cs, ongoing patient engagement is necessary to help patients manage their diabetes. So this one's pretty good. We have some data there. We have a time frame of the 3-month diabetic check. That's what we're looking at. And we have the impact statement. So actually, this one is pretty good. So the next one. The problem is that triage nurses aren't answering the phones. So we have a backlog of phone messages. So there's a lot going here. Let's start with the statement that says the problem is. Anytime you have a problem statement that begins this way, it's a problem. Not to use that phrase too often, but please don't say the problem is. Take that phrase completely out of there entirely, because that's very problematic. You do not want to have a problem statement stating that, because you're already assuming what the problem is, and you are pointing fingers here. The triage nurses aren't answering the phones. It's clearly their fault. In actuality, it may be something completely different. So let's revise this a bit and say, we actually have a backlog of phone messages in our system, 30 from last week and 23 from the week before. This is not only a liability risk, but a patient safety risk. And so this is much better because we have some data, we have a time frame, we have the urgency in here. It's a lot better. And I've actually seen something similar to this last problem statement, where they were assuming the cause was that staff weren't doing X, Y, or Z, but in actuality, it had to do with the phone system not forwarding things. So you really want to be careful about your problem statement, because if you are pointing fingers, if you're assuming the cause of the problem, you may completely miss the actual root cause. So having a solid problem statement is really, really important. So I wanted to show you an example of a real problem statement from one of the federally qualified health centers that I worked with to do their root cause analysis. For them, they looked at missing lab results, and they weren't sure if the patients actually attended the labs or not. They acknowledged that they didn't have that information, and they put in the impact that, if they don't have the lab results, it impacts how they're able to care for their patients. Okay, so now let's say you have your problem statement, you're ready to go. What's next? Before you actually dig into the root cause analysis, there's a couple of steps you need to do. I always recommend starting and having a parking lot. This is because it is human nature to have an idea about how to solve the problem as you're in the middle of your root cause analysis. Some great ideas are generated, always, which is fantastic. But you don't want them to derail your root cause analysis. So take them and put them in the parking lot. So you're saving them, you're capturing the ideas, and you're putting them somewhere safe, but you're not letting it derail your root cause analysis. Okay, so have a parking lot. Next, get your team together. The more multidisciplinary you can have it, the better. Try to get a facilitator if you can. A third-party one is always great because they don't have a horse in the race, but you can always have somebody that's part of your team if needed. Having clinicians as part of that, I know can be tricky, especially with time constraints, but they have invaluable information and can be a really key partner in this. You want to have your QI folks, and don't forget about non-clinical folks like front desk, IT. You'd be amazed at the information that they have around the processes, around all the stuff that's happening on the back end that you may not know is happening. So really get as much of a multidisciplinary team as you can. Anyone that touches the process in question, if you can get them involved, that's even better. All right, so let's dig in. The root cause analysis. I'm going to go over one of the first kinds of root cause analysis, and the one that I primarily use, and that's called the 5 whys. It sounds really simple, right? So you just ask why 5 times, and then you find the root cause, and then you can get the solution, and it's super easy and fast. Well, it sounds super easy and fast, but in actuality, it's kind of like branches of a tree, because every time you ask why, there's almost always more than one answer to that why. Sometimes there's many answers to that why, and it can really branch out, kind of like a big family tree that keeps growing. And for every answer, you need to ask a why. So it really does grow, and it does take time, which again is why I mentioned having a narrow, precise problem statement can really help you here, because it will focus that root cause analysis to a more narrow window, and then you'll be able to really hone in and focus your efforts, and it won't be quite so massive of a tree. All right, so asking why sounds simple enough, right? Well, yes and no. It's actually pretty tricky when you get into it to craft your why questions, because you don't want to point fingers at anyone. You don't want to place blame, or you want to, sometimes it seems like you want to ask what or how instead. And so phrasing it as a why question can be tricky. You really want to inquire about processes and barriers and systems. And so it can be a little challenging to craft the why questions. And the reason why it's so important to be careful when doing this is because it can steer the answers. How you ask a why question can influence the way people respond. And you can think of this as when somebody asked you a question and you misunderstood what they were asking because of the way that they asked it. So I have a few examples here I want to go through. So one example, well, why is Susan not following up on these referrals? Again, this is breaking the don't point fingers rule, because the answers could be that, oh, well, she's just lazy, or she doesn't care, or she's too busy. Instead, if we reframe this and say, okay, why are referrals not being followed up on? That's a different question. And the answers could be instead that there's no time set aside and it's difficult to track in the EMR. So if you notice that instead of pointing fingers at an individual, you're finding out that there's some process issues here, perhaps some IT things that could be figured out. So the answers really change when you change how you're asking the question. Another one. Why is our CEO not providing leadership and resources to this? Again, the blame issue. They don't see it as important, could be one sentiment, and I'm sure some people feel that way at times. But when we really look at it a little more closely, we can try to say, why is this project not a top priority for management? And instead, the answers could be something like, well, right now, the MAT and substance use disorder projects are taking up a lot of time and resources. Okay, so that explains things in a very different way. Okay, so if you're having trouble with the why question and crafting it, you can simplify things to say, why did that happen? Or why did this occur? Or just very simply, why? Because as you get into it and as you're going through the process, you'll see what I mean about sometimes crafting these why questions can be a little trickier than you would think on the surface. Okay, so I have a little snippet here of an actual root cause analysis that I've done. And again, this is just a tiny little snippet of it. So this has to do with that problem statement that I mentioned earlier around lab results. And as you can see, that goes through different layers. And if we look at down to question A, why are labs not completed prior to the appointment time? You can actually see a little I and then 2 I's, so 1 and 2 in Roman numerals. So there's 2 different answers there. And then for each one, you have questions going down. How we structured this was so that we highlighted the spots when we found a root cause, so that when we went back through it, we could easily find them and pick them out. And we could see the train of thought that got us there. So this is one way that I've used to structure root cause analysis and to really facilitate this with health centers in the past. Okay, so now I want to talk about another form of root cause analysis, another tool that you can use. These are called fishbone diagrams. Another way to think of them is cause and effect diagrams. And they're really helpful to look at different categories. So this is a way to really visualize what's going on and to look at things and see how they're related and see the relationships between them and the different categories. So it is able to connect the effect, which is the head of the fish, or the problem statement. That's where you want to put your problem statement, and the various categories. So those little blank spots that you see next to the arrows, that's where you would put each of the categories. And then you would have the bones be the causes, the whys, essentially the answers to the whys. This can be really helpful for visual learners to really see how everything is interconnected. There's some common categories used for the fishbone diagram. The top 3 that are listed are some really common ones. As you can see, sometimes there's only 4 categories, sometimes there's 8. There's no hard and fast number of categories that you need. The more you have, the more you can dig into different aspects. And all of these can be applied to healthcare. So they are all applicable. You can also look at this in terms of looking at functions or processes. So it doesn't have to be the categories listed above. Feel free to use ones that you think are most appropriate for the project that you're doing. And that will get you to the answers of the root causes that you're looking for. Okay, so how do you go about creating a fishbone diagram? It's actually pretty simple on the surface in terms of how to create it. The problem statement is your head, so to speak. So again, we want to use that foundation of the problem statement. And then you choose what categories you want, and you kind of put them and line them out so they're evenly spaced. And then you draw some lines that connect them all to the problem statement. And these are the bones, as I mentioned. And then how to actually go from there. You want to look at each category and ask a why question. You know, why is this affecting, why is the environment affecting this X, Y, or Z problem statement? Or how is staffing affecting X, Y, or Z with the problem statements? And then you have several different bones that will come out from that. And then as you dig deeper into each of those, they'll become little smaller bones. So then here is an example of a real fishbone diagram from the IHI. And you'll see here that we have some initial, the categories, and then the bones underneath them, and then subcategories. So if we look at environment and we go down to clocks, we have 2 subcategories under here. One is that the clocks are inaccurate, and another is that they don't agree with each other. So that's how this can be populated to kind of look like a fishbone diagram.
Kristen, we have one question again.
Sure.
Regarding the categories.
Mm-hmm.
Just what is the category part? Just need some clarification about categories.
So I'm just went back up to where the common categories are used. So this is a way to look at different aspects of your environment, of staffing, of workflows, so that you're examining different parts of your system within the root cause analysis. So the categories are things that I kind of think of them as buckets, almost different buckets where you can kind of look in and see, okay, how is manpower affecting our problem statement? Is it that we don't have enough staff? Is it that we don't have staff trained in this particular thing? So by examining each of these categories, you may find that there are things happening that are affecting the problem statement that you may not have thought of before. It's a good way to organize your thinking and to examine different parts that you might not have thought to do otherwise. And so that's one of the real benefits of doing a fishbone diagram, is that you have these categories to look at and really dig into. Whereas otherwise, go ahead.
No, the question is, are the categories fixed for the most part, or are these something that you put in? So these are fixed categories, but I'm thinking, they're wondering about, is it fixed or is there other categories?
That's a great question. So the categories that are listed here are just some common ones that are used. They're not by any means fixed or set in stone. You can use whatever categories are most appropriate for your project. So they could be something completely different than what you have here. So you can come up with, let's say, you want to think about community partners and how they all impact a problem statement. You could list them, or you can think about different steps in a process and list those steps, because it doesn't have to be something with just the environment and the staffing and the systems. It could also be looking at a specific process and breaking that apart into the different steps and looking at each step to see how does that step impact the problem statement. So it is really much more flexible than it might look like on the surface. So please customize it however would be the most appropriate for the project that you're looking at and the problem statement that you're trying to look into. Does that help?
Yes, thank you. I don't see additional questions, so thank you.
Okay, great. And thank you for the question. I appreciate that clarification. All right, so we're here. So then you may ask, well, which one should I use? Should I use the 5 whys or should I use the fishbone diagrams for my root cause analysis? These are really both valid tools. So it's really up to you and your comfort level. The fishbone, as I mentioned, is great because it breaks things down into categories, which can really help not only with the visual aspect of seeing the connections and the relationships, but also to examine things that you may not have thought to look at before. Whereas I found with the 5 whys, it's easier to go deeper simply because of lack of space on the fishbone to go too deep. That being said, you could combine the two and think about categories to use within the 5 whys, which would allow you to both use those categories for the fishbone and be able to go as deep as you need to with a 5 whys structure. So really it's up to you what you think is the easiest to use, what process you want to go with. Okay, so I get this question a lot. How do we know when we're finally at the root? There's a couple of ways to think about this. One is that if you can't go any deeper, if you can't keep digging deeper, then you're likely at the root. The other way that you'll discover this is when it becomes cyclical. And what I mean by that is when the answer to a why question is actually the answer to a why question earlier, and you start going in circles. And this almost always happens at least once during a root cause analysis. And then it's like, okay, we're at the root because we're going in circles here. So those are two ways when you can know that you are at the root cause. And I want to acknowledge too that there will very likely be root causes that are out of your control. We're not necessarily going to get Medicare to change their policies on something right away within our little organization. So there are going to be things that are just outside of your ability to change, but it's still a root cause. So you should still highlight it as such, but just knowing that it's not one that you're necessarily going to be able to have an impact on, at least not immediately. Okay, so now you have all your root causes. What next? Because I guarantee you, you will have a long list of root causes. It's not going to be just one. So how do you know what to act on? I have found that by prioritizing them, it can make it much easier, because you certainly can't address all of the root causes at the same time. That's unmanageable and unrealistic. So what I've done is I've used a prioritization matrix. There are a ton of different prioritization matrices out there on the web. Some are really complicated, others you need to purchase. So I just kind of took the idea and created a simplified version so that I could use that to prioritize root causes, and we would know which ones that we could really act upon. Things that we looked at within that were the impact on the problem statement. If this root cause was addressed, how much of an impact would it have? Would it really solve the whole problem, or would it just be a tiny fraction, or what kind of impact would it have? Because the other thing with root causes is that you'll find that some have a much bigger impact on the actual problem statement than others do. So that's an important piece to look at. Also, how feasible is it to work on this? Do we have, if we could get everything we needed, can we act upon this? Are we able to get everything we need? Can we make those relationships? Can we get those resources? Again, I think of the example of Medicare's policies and procedures. How feasible is it to act upon that and change those? Maybe not very, at least not within the typical federally qualified health center. That is usually outside of our scope. So this is the simplified matrix. You will all be getting a copy of this. It's in Excel. It's pretty customizable and easy to use. So what you would do is up there in the yellow row, you would put your problem statement. So you have your focus area. And then in the column under root causes, you would list all of your root causes. And the way this works is then the columns next to it, the impact on problem statement, the feasibility, urgency, actionable, those columns, you would rank each root cause for each of those columns, with 10 being high and 1 being low. So what that means is, let's say we have a root cause where it's really having a big impact on the problem statement. So we may want to assign a 9 or a 10 in the impact column for that particular root. And then feasibility, how much can we impact that? If we could get everything we wanted, if we could get the resources that we needed, how feasible is it for us to be able to do this? Then the urgency, some root causes are going to be more urgent to address than others. And you'll find that as going through, especially things that have direct impact on patients' health and outcomes, may be more urgent than others that are not quite as an impact on their health. And then the actionable question. So this one's different than feasibility, because actionable is looking at, can we do this tomorrow? Do we have the partnerships in place to do this? Do we have the resources we need? Do we have any finances that we need to be able to pull this off? How actionable is it? So again, you assign a number 1 through 10 for each of those, and then you tally it up. And the root causes that have the highest total sum would be the ones that would rise to the top. And I always recommend doing this with a group of folks, so that you have not just one person saying, oh, well, it's a 5 on urgency, but you have several people's input, so that it's much more comprehensive. And because different people will have different ideas about how to rank them, I always recommend getting the average and putting that in there. So,
Kristen, we have a question
yes.
before you move on. The question is, at this organization, they have an incident reporting system.
Mm-hmm.
And is that where most items would be identified? So this is several parts of the question. So they're asking if incident report system, if that would be most items would be identified, and then how do things make it into this list? Who should make the decision? The group, a few designated people, so there's consistency, or what makes its way to the list? And then also, how soon should a RCA be conducted?
Okay, there's a lot to break apart there. So for the incident command piece, it really depends on your system. I mean, so this was really identified for root causes and solutions, but it can certainly be applied to other aspects as well. So it's tricky to answer that question without actually seeing it and going into more detail. But this can be used to really prioritize any number of things. And again, those columns that say impact on problem statement, feasibility, et cetera, are completely customizable. You could change that to be cost or whatever you want those columns to be to rank them. As far as who should make the decisions on how to rank them, I think having it as a group decision is always preferable. Perhaps the same folks that were in doing the initial root cause analysis to actually come up with the root causes could be the folks that would then decide what the impact, et cetera, was, because they're the ones that have been discussing it and really in the weeds, and they know where that root cause came from. They know the train of thought. So that might be the most appropriate group of folks to put this together. That being said, that's an organizational decision. So if you decide that you want one or two or three different people to decide how to rank each of these root causes, that's completely within your purview to do. And how things get on this list. So this root cause list are really, so I'm going to go back a little bit here so I can show, well, actually I have an example next, but I'm going to go back to show you really quick. So bear with me. So the root causes. So here we have the highlighted yellow where we found some root causes within this example, this little snippet of an example of an actual root cause analysis. So had more staff being needed, that would be in the list. The fact that patients have a lot of things going on in their lives with social determinants of health and behavioral health complicating things, that would go in there too. Oftentimes it's helpful to phrase the root cause that it captures some of the previous questions that you are able to really get the train of thought within a sentence or two within that list so that it's clear where that root cause is coming from. Because if we just put more staff needed without the information about chart prep and then limited capacity and reminder calls, all of that stuff in there, that information would get lost. So summarizing the root cause and getting it into, bear with me as I go through these again, into this list of root causes here for one row for each root cause can really help to quickly summarize all of the root causes that you have found. So that's how that makes it to the list. Now, I think of the last question, and forgive me if I'm missing one, about when an RCA should be conducted. So that is an interesting question, because if you're thinking about your HRSA site visit, which if there are any participants who are not part of a federally qualified health center, all federally qualified health centers have HRSA site visits. Normally at which you have a performance analysis and a root cause analysis at. I always recommend doing the root cause analysis before the site visit because it gives you an opportunity to really explore the different root causes of a problem, to then brainstorm solutions for those root causes that you identify as priorities, and then make some PDSAs to act upon them. And it gives you much more time and flexibility to do that ahead of your site visit, as opposed to doing it during your site visit. That being said, right now, HRSA has made those optional while we're doing the virtual site visits. So it's really up to the organization if you want to take that path or not. And for doing root cause analysis other than the site visits, I always recommend doing it before you embark on a quality improvement project, because you do not want to go down a path of a change only to discover halfway through that if you had done the root cause analysis sooner, you would have found that the actual problem is this and not this, and you should have done that instead, and you wasted this time and resources. So when you identify that there's a problem, and it's a problem that's reoccurring, right? So I know for incidents that happen in a hospital, you may want to examine those quickly and look at root causes of that problem quickly. So falls or infections or things of that nature. Those are specific as incidents that are addressed on a rapid basis. The ones that we're typically look at for root cause analysis in this sense are things that are happening. There's a pattern, so we can see that things are not where we want them to be, or a process isn't working the way that we would ideally like it to be working, or we have some patient feedback that isn't ideal, whatever that might be. So again, we may identify the problem either through data that you have that's showing you something is off, or it could be anecdotally that you're seeing that something is not where you want it to be. Okay, does that answer, did I get all the questions, Darlene?
You did, thank you. Great
Okay,
memory. Thank you so much.
you're welcome. And this might help answer some of those questions too a little bit, because this is an example, a fictional example of a populated matrix. So here at the top, we have the problem statement about poor diet is contributing to the rise of type 2 diabetes, obesity, and high A1Cs. And then some root causes here that were from that. Again, if this was a real one, the list of root causes would be much longer, much longer. But this is just a fictional snippet. So we're looking at the focus area here so you can see how this is populated. So for the impact, we have some different numbers assigned here. I used nice whole numbers because it was just nicer that way. But again, because you may be doing an average from the different input from group members doing this, you may have some decimals in here. That's totally fine. And then for each column, we have a number assigned, and then the totals here. So for this one, the top root cause is actually the one where he says patients were not brought up to know how to cook raw or healthy or non-processed foods. So that one has a score of 23. So of the 4 root causes listed, that one has the highest priority. So if you look at those scores, just to review what the columns were in here, and again, these are customizable, so feel free to use these or not. We looked at the impact. So if we addressed this root cause, what kind of impact would it have on the problem statement? And it was decided here that it would be about a 6, because it would help for patients to know how to really work with raw vegetables, how to cook kale, that kind of thing. And it could impact their obesity and managing their type 2 diabetes. How feasible is it to work on this? If we got everything together, could we do it? And if we think about the possible solutions to that root cause, things like cooking classes, cookbooks, perhaps looking at different ways to teach patients how to cook these things. Yeah, it could be done. It's been done elsewhere. It's possible. It's not without our out of our reach. How urgent is it that to complete this? That was a little bit lower of a scale because it's not quite as urgent as, let's say, someone's blood sugar is being way out of control. And how actionable is it? How much stuff do we have to be able to pull it off tomorrow? And whether or not something's actionable is really going to depend on your organization, what you have available to you, your resources at your disposal. So this is going to, even if you had the same exact root cause as your neighboring organization, the actionable column will be different for each of you. Okay, so let's say now we have our root cause that we decided, okay, this is the one at the top. We're going to focus on this one. So what next? Next, you're going to brainstorm some solutions. And this is one that really benefits from a team. Focus only on one root cause at a time, because otherwise you're going to confuse things. And you may find too that a solution that for one root cause will also address a couple of others, and that's great, but really just still focus on that one root cause at a time. And all ideas are valid. Anything goes. You're writing things down, you're just capturing all the ideas. And the reason why I say this is because something may sound silly to you and you may not want to write it down, but if you write it down, you're demonstrating that you're going to take everything seriously. And so the person that was hesitant, who didn't really want to speak up because they're a little nervous, they're going to be more likely to speak up because they're going to see that, okay, they're taking everything seriously. Maybe I can share my thought. There are lots of different ways to do this brainstorming, so don't limit yourself. You can use sticky notes that you hand out to folks and they write things down, they come put it up at a board. You can use a whiteboard. You can use there's some neat brainstorming tools that work in the virtual environment now too. So even though many of us are working from home or are spread out, that should not stop you from having a team to brainstorm. There are pretty neat tools out there that can help with that. And I want to make sure to note too, if you notice in your group that you're not really hearing from one or two or more individuals, talk to them privately. Oftentimes in a multidisciplinary group, it can be intimidating to speak up. If you're the front desk staff person or another staff person without clinical expertise and you have some physicians in the room and the CEO in the room and you don't want to necessarily give your idea because you don't want to, you think that the physician's ideas are more important. And you'd be surprised at the ingenious ideas that folks have if you just talk to them privately and really get their thoughts. So really make sure to do that. I guarantee you they may have some ideas that you may not have thought of because they have a different perspective. They have a different viewpoint of what's going on. And so they may be able to come up with a good, simple solution that the physician may not have thought of because they have a completely different viewpoint of what's going on. This is also, yes.
Just have a question right quick. When you were doing the example before on the matrix, the question is asked about the poor diet.
Oh, yes.
Is this an assumption or is it because this fact is known and it's taken as a fact? And is that okay?
That is a great question. I love that you're asking that and really looking at assumptions there. So this problem statement was based on some research, but yes, generally that kind of thing can be an assumption, especially if we're expanding diabetes to include type 1. That's as most of you know, that's completely erroneous with type 1 diabetes. So I'm so happy you asked that question. So looking at your assumptions for everything is extremely important. And perhaps here we should have included some of the research that was looking into the diet and the relationship here to type 2 diabetes. And this was also including, this problem statement also includes obesity, which isn't always a correlating factor to type 2 diabetes, right? We do have those patients who are not overweight and still have type 2 diabetes. So looking at those assumptions is really important. Thank you. Okay, so solutions. This is also where you want to revisit your parking lot. Remember in the beginning when I mentioned having a parking lot for all of the ideas that are coming up along the way that you want to capture and put somewhere. This is when you look back at that and say, okay, would any of these work? Are any of these applicable to the root cause that we're looking at? Because sometimes the ideas in the parking lot are great ideas, but apply to a different root cause. So include all of those that you can. And then once you have your nice big list of different ideas, that's when you want to use the prioritization matrix again. And I personally feel it's more important if you're going to use the prioritization matrix for either root causes or your solutions. I feel like it's even more important to use it for solutions than the root causes. Using it for both is ideal, but if you only have time to use it for one, use it for the solutions. And the reason I say that is because you want all of the solution ideas to be on an even playing field. And by using this matrix, which is slightly altered for the solutions piece, you're putting everything on the same playing field. The idea from the physician is on the same playing field as the idea from the CEO, as the idea from the front desk staff person. So that way they're all given equal weight and everything can be looked at in a quantifiable way. It minimizes the tendency to play favorites to try and appease certain individuals of the organization. So it can really be a way to make sure that all of solutions are given equal consideration. The slightly different thing that you'll see here for this matrix as compared to the one for the root causes is that we have not only the problem statement here at the top, but also the root cause. Because remember, we're trying to look at that one root cause that aligns with the problem statement and look at those solutions. So this kind of ties it all together. Also, with the columns, we have a consideration of cost in here because we all know with our organizations, many of us are grant funded, cost does come into play. So it's something to take into consideration. Again, all of these columns are completely customizable. Do what works best for your organization. You can have less than 4 columns. You can have more than 4 columns to look at in terms of ranking. It's completely up to you. This is really meant to be customized however you see fit for your organization. Okay. Are there any other questions before I move on, Darlene?
No, not at this time. Thank
Okay.
you. Oh, I'm sorry. Yes.
Okay.
I just looked at the chat. I just looked over. So here's a question as far as how would you define impact on the problem statement on the priority matrix? So let's answer that one. And then there's another kind of question here. So can we just answer that one? Mm-hmm.
Sure. So this is for the proposed solution. So let's say that if you take this solution and you implement it and you're successful with it, how much would it impact the problem statement? Would it have a good positive impact on it and it would solve it completely, which would be amazing and is not usually what happens. Usually it solves it to some degree, right? So different solutions are going to have different levels of impact on the problem statement itself. So whether or not they're going to really solve those problems that you're seeing, or if it's going to have a little bit of an impact but not go as far as you'd like, that kind of thing, because you will see a range. just like with the root causes, how you'll see a range there about how much that root cause has an impact on the problem statement, how much that root cause is actually causing the problem that you're seeing. So how much would this solution fix the problem that you're seeing? So that's how the impact between the solutions and the root causes are a little different. Does that make sense?
It does to me. So the second
Okay.
part of this question is, are the number rankings defined?
Well, yes and no. So they're defined in the sense that it's a 1 to 10 scale, with 10 being the highest, so 10 being the most beneficial. For example, if we looked at cost, if we rank something as a 10, then it's the most cost effective, that we can afford to do that. It's within our budget. A 1 would be it's out of reach financially, because we want a total here to be the higher the total, the more achievable that solution, the more we should prioritize that solution. So the 10 in this case for this prioritization matrix should always be on the more like favorable. 10 is the most favorable and 1 is the least favorable. So for actionable, 10 would be, yes, we have everything we need, we can start tomorrow. And 1 would be like, no, we have to get this machine, we have to get these partnerships in place, we don't have anything we need. Okay, so that's how the scale is kind of defined, but it's not broken out any further than that. But it is, you definitely want the higher numbers to represent the more favorable piece of each of those columns.
Great. Thank you.
You're welcome. And keep the questions coming too. I really do appreciate that. All right, so let's say you got your root causes, you figured it all out, you went through that whole process, you were able to brainstorm some solutions, you got your team together, you prioritize them, and now you know what solution you want to implement. So now what? Now is when you dive into your PDSA. And that stands for a plan, do, study, act. It may also be called a plan, do, check, act. They're essentially the same tool. This is a continuous quality improvement tool. You'll see it come up time and time again in QI. And a continuous quality improvement tool is a way to kind of look at a problem and kind of go through this whole process of planning it, implementing it, analyzing things to see if they're going the right way, and then tweaking things and keeping going. So I'm going to break this down a little bit. The plan phase is really where you want to bring in your problem statement that you had. So you want to keep that. That is your foundation and your identified root cause. It's also where you want to identify your measures and collect your baseline. I'll talk more about that momentarily. You create your action plan and set your goal. And I'm going to talk about those in a few minutes too. The do phase is really when you take your selected change, what you want to do, and you implement it. You go out and you start doing it. And you're measuring things along the way, right? You're collecting data along the way so that when you get to the study phase, you can actually analyze that data and figure out, is it going the way we want it to go? And the act part is when you tweak things and make adjustments. And it is exceedingly rare that you don't have to make some kind of tweak or adjustment. Please know that when you get to the act phase, if you need to change something, that's normal and expected and does not mean that you failed. It's a continuous quality improvement for a reason. It keeps going and you just got to tweak things and keep going. And when you get to that act phase, talk to all of your team members. Talk to the folks who are implementing it, all of them. They can tell you what's working well and what's not. What little thing might need to be changed? Maybe instead of having something on paper, it should go into the EMR instead. I mean, there's all kinds of little things that could be tweaked to make a process easier. And ultimately, you do want a change to be as easy as possible so that it can be implemented and adopted as quickly as possible. And it will take time. All right.
Kristen, we have one question that just came in.
Mm-hmm.
It's talking about the ranking. So it's the question is, when identifying impact on solution or root cause,
Yep.
do you find teams struggle with a 1 to 10 ranking versus a 1 to 5 ranking?
That is a great question. So we've definitely found some variety in the numbers assigned. We always take the average. And again, you can use a 1 to 5 ranking. That would work just as well, as long as you still keep the notion that the higher number is the more favorable one and the lower number across the, all of the columns that you're using, all of the criteria, and the lower number is the least favorable. That way your sum, so I'll go back to that real quick so you can look at this. The sum over here, the total, will be indicative of what should be a priority. You always want the total to be something where the higher the number, the higher the priority. So it's really important that when you rank things, that even if you use 1 to 5 or 1 to 10 or 1 to 20, whatever ranking scale you would like to use, that the higher the number is more favorable, the lower the number is least favorable, so that across the board it is consistent. Otherwise, you're going to get some really skewed numbers and it's not going to tell you which ones are priority. Okay.
Thank you.
You're welcome. So this is a template that we use at BiState for our PDSAs. Again, it's just an example. You will get this as well as part of your resources. We're sending it out. This can be tweaked. It's just a template. So you can use this for a PDSA. There are lots of other templates out there. Use what works best for you. That being said, writing down your PDSA may feel a little tedious, but it actually really, really helps in the long run because you're able to kind of really line out all of the different pieces. You have them in one place. You can look back at them, and it's good for reporting too. When you need to be able to report on a quality improvement project, you can show them in one place, your PDSA and what you've done so far. So I always recommend writing them out. You can use this template, you can use another one, as long as you document what you're doing, because as that saying goes, if you didn't document it, it didn't happen. All right, so I'm going to dig into the planning phase a little bit more. As I mentioned, you want to include your problem statement. This is your foundation, remember. Your identified root cause and the solution that you came up with, what the changes that you want to do. You also want to outline what the next steps are. So you have the solution, so what now? Who needs to do what, by when, and lay out all those little pieces. Because the more you're able to detail these action items, the next steps, the smoother the process will go. During this, also think about who can you collaborate with. The more you're able to partner with external stakeholders, with community partners, the more you're able to kind of spread out the load, work together. Almost always your external stakeholders are interested in you succeeding in a PDSA because it can benefit not only your organization, but it can benefit them because oftentimes they're patients at your health center, or they have a shared mission about serving these patients. So always reach out to your community partners that you think may be interested in this, in the particular project that you're doing, so that you can work together as a community. I've seen some amazing things happen here in Vermont when communities come together to work on projects. There's some really incredible examples. And so don't work in a silo. Really reach out. You'd be amazed what can happen from it. Okay, so I'm going to talk about measures in a little bit also, because that's really, really important. Think about what resources you need to pull this off, not just to actually implement the change, but also for data collection, because you need to be able to collect information and data about whether or not the change you're implementing is working. So think about that before you implement anything, because you're going to need to collect that information. Also think about what your goal is. You need a goal to start out, and we'll talk about SMART goals momentarily. So again, with your community partners, there's all kinds of folks around you that have an interest in seeing you succeed. So think about all of them and if it would be applicable for them to be a part of this. Okay, so data. I love data. I'm a bit of a data geek, but it's important to really know your data. Think about what available sources you have to you. Think beyond your EMR. You have resources out there that, let's say not just UDS, but also there's other data sources out there. Please use them to your advantage. As long as they're applicable to your project, go ahead and pull them in. Always, even when looking at data in your EMR, know what criteria is used. Is it actually the patient population that you're looking at? Is it the same time frame? Is it old data? Is it still relevant? Know what criteria is used in every data piece that you pull in. And is the data telling the truth? So this one is important because you can think of, say Dr. Jones has a cervical cancer screening rate of 0%. Well, so you go to Dr. Jones and you ask him, what's going on here? Turns out he's doing plenty of PAPs and doing the cervical cancer screening. It's just not getting documented where the report is pulling from. So the report and the data was not telling the truth in this case. So always look behind the data. The number only tells you one part of the story. Also, equally important, make sure the data is telling you the story you want to learn about. And what I mean by that is that sometimes measures, they're really useful measures and they're important and great, but they're not directly applicable to the project that you're working on. So therefore, they're not going to tell you if your project is successful or not. And I'm going to talk about that more in a second. It's also really important to not just look at percentages. Always look at the numerator and denominator behind that percentage. Because if you have a denominator of 2, those percentages are going to be wildly skewed, as opposed to if you have a denominator in the hundreds or thousands, that's much more reliable in terms of the consistency of the percentages. Okay, so measures. Helping to select measures for quality improvement projects is something that I do frequently. And this is because it's not always as intuitive or easy as one might think. The measures should always include a numerator and denominator. But you need to make sure that your measure is actually telling you the story that you are trying to learn about. An example where I saw an actual example where they chose a measure because it was easy, they're already collecting it. They were looking at patients with an out of control A1C. That's the measure they were using. The project they were implementing was to get patients in for their labs, for their A1C labs that were, hadn't come in for a while. They're trying to get more patients in. And that measure that they chose the UDS measure because they were already collecting it. It was easy, it was there, of patients with an out of control A1C. After they re-examined it after their project, they found that that measure looked much worse. You know, things, it looked like it got a lot worse. It looked like their PDSA was a complete flop. But then I sat down with them and we looked at instead the number of patients that got in for their labs, for their A1Cs, the rate of patients who were overdue for their A1Cs. And when looking at those measures, they actually found that they were quite successful. The reason that outcomes measure from UDS around looking at patients with an out of control A1C was so awful was because they got so many patients in who hadn't been in a long time and their sugars were way out of control. So it skewed that outcomes measure and made it look like their PDSA was unsuccessful, when in actuality, they were very successful with the project that they had done of getting patients in. So choosing your measure is very important. Don't just go to outcomes measures because they are the easiest. Really think outside of the box. Make sure it's measuring the change that you're implementing so that you're learning about the story that you're trying to learn about. Okay. I want to take a moment to talk about qualitative measures, because sometimes the information you will need to learn about is more qualitative. It's observational based. It's not based in numbers. It's not like you know, an easy numerator denominator that you can pull out of a hat. And so how do you measure that? You know, you can think of an example of trying to figure out if patients are eating healthier after a nutrition class. How do you measure that? So you could look at, for example, you're doing before, during, and after the class, picking out some important things that matter to you. So let's say the number of sugary drinks consumed. So we could look at the number of sugary drinks consumed before, during, and after the class to see if patients are eating healthier. Of course, there's always challenges with this type of data collection, right? Because you're relying on self-reporting. That's a whole separate issue. But you know, we rely on self-reporting for a lot of things, and it's the best we can do sometimes for converting qualitative data to quantitative data. You can try to use a scale. I think of you know, the patient experience surveys. Sometimes there are scales in there that you can use. You can also try to group comments. You'll say from a patient experience survey that are qualitative in nature, you say that you got 10 surveys and 3 of them had negative comments and 7 had positive comments. So you can group them in that way. So that being said, always try to structure your data collection during the planning phase ahead of time as much as possible so you can get quantitative data wherever you possibly can. It will make your lives easier in the long run to be able to figure out if a PDSA was successful or not. Do we have any questions, Darlene?
Not at this time.
Okay. So I'm going to take a moment to talk about SMART goals, because this is something that happens in your planning phase too. And it's really important to have a good SMART goal, and that is an acronym. So that stands for specific, measurable, achievable, relevant, and time-based. So you want it to be really specific and precise. What are you looking to do? Measurable, again, that goes to the measures that we mentioned. Where you are at now and where you want to be. Achievable, making sure you can actually pull it off, being realistic. I can tell you that in vast majority of cases, getting to 100% on something is not realistic or achievable. So really think about what's possible, because you don't want to set the bar so high that folks feel like they can never meet that goal and they feel like they're failing. You want to make sure it's achievable and folks can actually get there. You want it to be relevant, of course, to what you're doing, relevant to the problem statement, relevant to the root cause that you selected, and time-based. You're going to do what by when. It's not going to be ongoing for years and years and years, but when are you going to measure it again? When do you want to reach this goal by? And that time base will vary depending on the project you're doing. It's possible for some projects that you'll want to see results within a week, but for others, like a change in A1C, you're going to need to have a much bigger time frame for that, because you're going to need to look at those 3-month A1Cs. So your time frame is going to look much different than it would for something else. So be realistic with your time frame too. What's going to be actually actionable for that? Okay. So I have a few examples here. So one goal, to aim to get patients to stop no-showing. Now this really needs improvement. We're pointing the finger here, where the tone is really way off. So let's try it again. To reduce no-shows from our baseline of 10% to 8%. That's better. We took out the blame. We have some data, so that helps, but it doesn't tell us exactly all of the pieces we need. So let's try again. To reduce no-shows from our weekly baseline of 10% to 8% within 1 month. Okay, this one's the best. We can go with this. All right, so I'm going to try to go a little bit quicker through the rest because I'm realizing we're getting short on time. So next, we really develop the action plan. This is the who does what by when. It's really important to assign tasks and to be clear. Don't assume that Joe is going to do this thing because you think that falls within his purview. Make sure it's assigned and that he knows about it. Create a deadline and hold folks to it, but talk to them frequently, check in. Is there a barrier getting in the way from them reaching their deadline? And there will almost always be something that comes up that prevents them from meeting their deadline. So work with them, see how you can help them to resolve that, how you can help them to overcome that barrier. And meet regularly. If you don't meet regularly, this will fall to the wayside, it'll go to the back burner, and the status quo will just kind of kick in. Meet regularly. Here's an example of an outreach plan. We can see that we had the tasks to be completed, who's going to be doing it, and sometimes you'll see that there is a team of folks doing it, not just one individual. When it will be done by, what's needed to actually complete those steps, and what the status is. This is a living document. You're going to look at this each time you meet to see how things are, where they're going, and what needs to be done. Okay, so when you implement those changes, when you get in the do phase, get buy-in. Change is really hard, and you really want to get everyone on board. The sooner you can really involve the folks that are going to be part of this change, part of this process, and impacted by it, the better. That's really a good way to get them to be a part of the process, and so get them to be able to actually implement the changes you want. Make sure they really understand what you want them to do. Don't make them play guessing games. No one wants to do that. Have a contact person so that if they have questions or things come up along the way, they know who to contact. Almost always the process looks pretty clear until they're doing it, and then they run into an issue and they're like, oh, I don't know what to do. Have a contact person so they know who to contact to say, hey, this came up and now I don't know what to do. Help. And this also goes along with checking in frequently to make sure that things are going the way you want them to. And along this process, as this will be implemented, that's also when you may identify some tweaks that need to happen along the way. So take a note of that and make sure you examine that regularly. This is just a kind of a little diagram that I like that kind of visualizes the change process for folks, because it's kind of like falling off a cliff sometimes. Stopping the way you're doing things, the way you've always done them, to suddenly do them a different way is really hard, and people resist it, and it'll be tricky and take time before it becomes a new status quo. So don't give up. Some quick tips. You want to make sure leadership is on board. If leadership's not on board, it will not succeed. If you can find a clinical champion, that will make your lives a lot easier because they can really rally the troops, be passionate about it, and really have a huge impact on the whole quality improvement project. I cannot stress enough how much communication is important. Communicate regularly, frequently, and be transparent about the whole process, what's going well and what's not. Be really transparent. As I mentioned, involve everyone who's going to be impacted from the very beginning. Celebrate any small successes and make results visible. This could be something as simple as putting a graph in your staff room, so just something that they can see, or emailing it out since many of us are virtual right now. And check in with folks. Make sure they have the support they need to really do this. And don't give up. You never know when you're almost there, that you've almost got it. It can seem like a long haul, but oftentimes it's really worth it. Okay, so I made it 5 minutes to spare for questions. So please keep the great questions coming. I want to remind you about the evaluation that Darlene mentioned that will be coming up at the end of this call. Please fill that out. And I have my contact information here. Please feel free to reach me. Email is the best way since we are working from home because of the pandemic. So I want to open up the floor now to see if there are any questions.
There are no questions at this time,
Okay.
we have a few more minutes. So if anyone has questions, please enter them in the Q&A. I'm monitoring both the chat and the Q&A. So I see we do have a Q&A. So let's see. Do you encourage your health centers to engage patients and those served in the root cause analysis stage?
Yes, that's a great question. Thank you so much for asking that. Whenever possible, yes, 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 because you'd be amazed at the information you learn when you can involve patients in a root cause analysis or in any quality improvement project. They will have insight into things that are happening that organizationally you may be completely blind to. You know, who knows, maybe your phone system is really hard to get through, and that's why patients aren't doing X, Y, or Z, or scheduling their follow-ups. You know, I've seen that happen before. So involving your patients anywhere you can is extremely beneficial. Great question. Thank you.
Someone asked, have you had success with a virtual root cause analysis, RCA?
Yes. So actually, because of the pandemic, we've been forced to move to all virtual. So I just completed one last month with a health center. It was completely virtual. I used personally, I used OneNote, but you can use any software, and I used Zoom and shared my screen so they could see what I was writing as I was writing it. And I was facilitating the session, and we had a team of folks in, some that were together in person, others that had called in via Zoom, and they were all able to participate because they could see what I was typing and see the screen, and we were all able to communicate that way. And so they could see if I was you know, if what I wrote really captured what they were saying, and it worked quite well that way. So yes, you can do it virtually.
Great, thank you.
Mm-hmm.
And I don't see any more. Everyone has been asking. I'm going to bring myself back on camera.
Okay.
There have been several questions just about the slides. Yes, we will be sending the slides out as well as the document that Kristen identified in her presentation, the matrix. So you will be getting that as well. And I did put in the chat that we are doing we'll be doing 3 follow-up sessions from this session. If you'd like to join those 3 sessions, just email me and we will get you included into that. Are there any other questions? We have about 2 minutes before we end. I just want to thank you so much, Kristen, for your training. This has been great. I have learned so much, and your examples have been just excellent, and just so thorough with your explanation. So thank you so much.
Oh, good.
And people are saying that in the chat as well. So
Oh,
um,
excellent.